Good morning, everyone. Welcome to New York. Here, me and Dr. Singla are welcoming you to Mount Sinai for our monthly endovascular live case webcast, where PK and his team are going to bring in a very interesting case for us as we do every month. As we go over, I'm just going to redo everything what we normally say every month. The previous cases have been archived into our live our webcast, into our website at www.peripheral-interventions.org. You guys can go in and watch it, and please ask us any questions you need, and we'll be very happy to answer it. The next monthly live case webcast is on September 26th. We look forward to seeing you again as we do every month, and without any further delay, we'll go to the cath lab. PK, good morning.
Hey, good morning, everyone. We have a fantastic case. Again, we'd like to welcome you to Sinai. We've got Dr. Kapoor, who's with us, as always. We've got Asma, our new interventional endovascular fellow. We've got Ray, as always, with us, and Elizabeth and Damien. We've got a really fantastic case here, which really highlights some of the decision-making processes and when to do approaches. And I can tell you, part of the inspiration for me and Vishal and you to think about this case was, there's been a lot of rage on pedal access and probably a little bit of overuse in probably our opinion. And I think, so we wanted to really show a case in which I think it's very, very applicable to do fem-pop intervention through a pedal access. And I think this case will illustrate to our audience, some of the complexities in the decision making and how to do it in a way that's safe and effective for the patient. And you'll see the thought process that goes into what got us to this point to show this case live and to teach you how to do this procedure on your patients and keep your patients safe and have a very, very good outcome. I know Vishal and I have spoken about this, how there's a lot of, in our opinion, overuse of pedal access for fem-pop intervention. So with that introduction, I just want to have Asma introduce the case, and then we'll interlude, and then we'll talk about some of the other things.
Good morning, everybody. So we have a 71-year-old gentleman who has diabetes, hypertension, dyslipidemia, prior history of coronary artery bypass surgery in 95, AAA repair in 2006, has also a aorto-bypass and had an occluded left limb, which was further treated with thrombectomy and a covered stent. I'm saying all this because it's going to be relevant in our case discussion. He recently also had, within the last year, also had a revision on the right side. He had a fem-pop bypass done. So he complains of 1 to 2 block claudication, left greater than right, and he's on the usual medical therapy. His creatinine is 1.3 today, and his hemoglobin and iron are within normal limit. Next. This is the demonstration of the inflow. It's a still frame from the iliac angiogram DSA, just demonstrating how acute the angle of the bifurcation is. And also, I don't know if it is showing through well, but the left limb proximally is stented with a covered stent. Next. I'm going to let this video play in a second here. Yeah. So he has basically one vessel runoff below the knee, and that's the lesion we're going to treat next. Next, please. Yeah, that's the lesion we are going to treat today. That is basically a popliteal lesion, about 80 to 90% stenosis there, moderately calcified. Next. This is he had a prior SFA intervention done on the left side as well, about a year back, through left radial axis. And this is a still frame from his left radial axis. We have a wire down there. I just wanted to demonstrate how extremely tortuous his left radial was, the left subclavian was. And not only that, while we were doing the procedure, because of such tortuosity, and he has a lima over there, so he developed some ischemic symptoms, and he started having chest pain during the procedure. With that background in mind, next slide, please. So here's what we thought about how to deal with the left pop lesion. So we wanted to do left pedal axis. And initially we decided that for visualization we would do a right radial, but when he came in the lab, it seems like his right radial pulse is not that great. He probably has A lines and stuff placed there before. And then we wanted to use a 4-5, versus we can talk about a 5-6 cylinder sheath for our pedal access. Therapeutic anticoagulation, we are going to use Angiomax in this case. We can discuss if there is a need for atherectomy. And
Not
also,
yet, we've got access.
yeah, and also we'll treat with PTA followed by DCB. Hopefully, we're going to try to do this without stenting if there's no dissection. So with that,
So I think that's a good presentation, and we want to just talk a little bit about some of the decisions that we had. So here so if you look at the lesion, it's underwhelming, right? I mean, you look at this lesion and you say, oh, okay, a live case for this particular type of lesion. Well, why is there such a live case? Well, so he has no options here. So he has been considered and was approved, and we were actually working him up for a fem-pop bypass, and with our surgeons, who are probably the most conservative surgeons in terms of bypassing for claudication, because they just simply refuse to do it. He is incredibly limited from this particular lesion, and the SFA in the proximal, which he had earlier, this is a new lesion, that's a de novo lesion. It's never been touched. The SFA proximal lesion, because of his numerous problems in his groin and as well as the numerous surgeries, what was failed to be mentioned was he had an endarterectomy as well on that side that precludes an antegrade access because it was done twice. So the surgeon, as you can imagine, was very not thrilled about doing a fem-pop bypass through a redo groin. So therefore, when we suggested this approach, it was definitely met with a lot of enthusiasm. So Vishal, when you see this kind of case, okay, here's a gentleman who has obviously right radial pulse is not good for access. Brachial is definitely an option, but clearly a lot of subclavian and aortic tortuosity. Left radial is no longer an option because of what happened with the last time. It was very difficult, and he was not very comfortable as we were doing it because of ischemic symptoms. Contralateral access up and over is not an option because of that covered stent. Antegrade access is an option, but it's a high-risk option. I mean, is there any other things that you would consider before you do pedal access in this patient? Was there any other type of option that you may consider?
No, I mean, clearly illustrated out. I mean, the idea is to trying to get access on what you're comfortable with. So in this case, we don't have real other options. I'm not a big fan of brachial because we know the complications can happen with brachial where you can get into more trouble than what you started with. Antegrade is always a great option. A lot of people do direct antegrade access for below the knee interventions because it gives you more support. But in this case, because of multiple surgeries and fibrotic groin, it's more of a technical limitation. So if surgery wasn't an option, I would probably go antegrade first in this case and then pedal. But because we have limitation with antegrade access, pedal is perfectly acceptable option. I guess the question people usually ask is, if you have only one vessel runoff going down the leg, do you want to really cause a trauma or iatrogenic trauma at the side, put a sheath in and do intervention? What would happen to the vessel? Well, I guess that's the biggest question, and which everybody needs to answer.
And this is this is why the decision making becomes so important. So here, Karthik, you see, and Sandeep, you can see the tortuosity. You can actually see the Vibon inside.
So I think even from brachial is not an option here, PK, because of that covered stent.
Right.
Once you put the sheath through that covered stent, there is such a high risk of thrombosis.
Right, and that's what we were going through last time.
Yeah, I'm sure he will have a lot. He must have had some discomfort when you actually went through that graft, right?
Right, and without a question, and also you worry about the operative site and the aorta and all that.
Absolutely.
So this is, I just want to show you the proximal SFA is where we did it. There you can see all the clips from the redo groin that he has had, and then you can see that's actually a very healthy common femoral. But you can see the proximal SFA has done incredibly well with just plain DCB. Right. All we did was this over 2 years ago now. We just did an impact balloon in the proximal SFA, and he has done phenomenal. And he had relief of symptoms. He had some neuropathic symptoms, but that was easily controlled. But now this is a different type of situation. And I could see the mid SFA is just moderate disease, no increase in velocity shifts over here. And this is the level of the popliteal, and you can see here he's got that very, very tight lesion right at that spot, and it got some moderate disease up top, which we can talk about. And then he has an anterior tibial artery that's very robust. And then you can see here that the posterior tibial peters out, perineal is coming down to the foot as well. And then the foot shot, you can see in this level, he moves a little bit because we were giving a lot of dye. You can see here the dorsalis pedis is the dominant vessel, and you can see that the perineal does come. And this goes back to what we talked about with Vishal, what Vishal brought up so nicely. Well, getting access in this vessel, and this is the only vessel that's feeding his limb, and you could technically say he's a claudicant. So, you know, and I think, as you know, Karthik and Sandeep and Vishal, all three of you, a lot of guys are doing FM pop through the groin, through the foot in the OBL. So, you know, talk to me about what you guys think is the natural history of this. I mean, I know we don't have any ideas. I do have some data that I want to share with you, but let's go ahead and talk a little bit about that. I mean, how do you guys feel about getting access in this solitary vessel?
I do a lot of transpedal speaking. You know that. I mean, especially ultrasound-guided interventions, I do a lot. But I personally feel pedal first is not the greatest option at this point of time. It's not only because the technique issues. I think radials and pedals are different, and there is not strong data. It's a good area to do some research and see. I personally feel it's okay to do a sheetless access. Putting a sheet itself just puts them at a very high risk for transpedal closures. But again, TAMI techniques have been successful. A lot of people have used it. Some people primarily use it for interventions. My only question for you and Vishal and Sandeep would be is, do you guys want to access the only vessel which is there, or would you think it will be okay to access posterior tibial? I don't know what you see in ultrasound.
Well, so I'm taking an angiogram of the posterior tibial for you now, right? So that's your posterior tibial artery.
So you do have a posterior tibial. I mean, if you put a sheath into that posterior tibial, right, you might be able to open it, but again, I think it might not be a valid.
So this is the question, and that's why I took this picture, because I think that this is the decision. I mean, obviously the dorsalis pedis is going to be one option, which we could do. But the thing is, with a 5/6 slender in this posterior tibial, before we get to the sheet size, let's talk about how you're going to treat and what are the decisions that you're going to make. I know we're already talking about how we're going to treat this. But in terms of that posterior tibial, I don't think that's going to take a sheath. You know, I don't think that's.
I mean, that's a primary vessel, right? It still goes to the level of the foot, right? Beyond the level of the ankle. So it's just disease vessel. So accessing that vessel and putting a sheath through that vessel. And if you actually put a 2.5 balloon or something, you might even create an access point for you.
Well, the idea would be here is, I think that Vishal, maybe you could talk about what your final treatment option would be in this particular vessel.
Exactly.
Before you decide, like, what is your final treatment
Well,
option?
I guess, Karthik, you have to figure out, right? I mean, this is more of a case where, like PK said, it's more of a claudication case, right? So if it was primarily an ulcer, which is more of an angiosomal or an arterial focal directed lesion, I agree with you, I would have probably gone PT if it was in the PT territory. But right now our goal is to do a quick focal lesion of the popliteal with minimal trauma, minimal exchanges, minimal additional steps, so we can give him the maximum benefit. So in this case, probably AT, which is the healthier vessel, you'll see on the ultrasound as well as angiography, it looks healthier than any other vessel. My goal will be to try to get access into the AT, fix the posterior tibial, probably plus minus atrophy. We talk about mainly DCB treatment, if I can avoid a stent, and just give him symptom relief and follow him up.
No, that's a very valid option, only because he's a claudicant. I mean, that's a very valid option.
Well, but you know, I think you make a good point, Karthik, and maybe Sandeep can comment on this as well. In that, you know, if we had even a moderately diseased posterior tibial, I would agree. But in this vessel, I think you have to understand that no matter what you do to this posterior tibial at the level of the ankle, you're going to sacrifice this vessel when you get in.
Yeah, I'm just saying that it's a CTO. You might as well keep it as a
it's
CTO.
not a CTO. It's very diseased. I think when you put a 4-5 slender in this vessel, even though you are probably going to close it. Now, the reason is that's where I think Asma has got something on equipment, which I think is very important, because when you think about what is the equipment you're going to use here, you need to see in your mind, well, what are the benefits of what I'm going to do versus what is the risk for the patient. So let's talk about sheet size, lesion morphology, lesion length, and expected patency. Let's talk about that. Let's show the lesion, right? Actually, let me take a better picture of you. Actually, Vishal will show in a second, but I don't want to give him more dye. You have a short lesion, which is probably the most severe lesion, right?
Right.
Let me go back to that lesion field.
It's about 4 centimeter lesion.
Right, let's take a better picture. This way you can tell me based on good information what you're going to do. Right, there's the level of calcium. Right, so now let's take an injection.
Right.
So try not to move. So you got moderate to severe calcium, right? And there's see the lesion right below. So you have two areas of lesions. You have a very tight 99% lesion, which is likely giving him his stenosis, which is where the velocity shift of 350 or 400 was there. Then you have some moderate disease up top. So one of the options is leave the moderate disease alone. I'm going to fix that focal lesion and get out of Dodge. Okay? We know he's done well with DCB. So one is, what is the expected patency, Sandeep, you think in this lesion in all the DCB trials?
So I think what we have, the maximum data we have is from impact, and with a focal, if we are just treating that distal focal lesion, we have a 3-year patency of more than 80%, 80-85%. So that would be one consideration. I think what will happen is if we start treating the proximal disease, that 4-centimeter calcified lesion, I think the chance of significant dissection is at least 20 to 30%. And then in the POP area, if we have to put a stent to cover that dissection, we are talking of supera, then our sheath size goes up. So I think that's what Asma has some data, and we can kind of discuss that. So it becomes important if we are treating from the AT axis. I want to keep my sheath size minimal. I want to treat his symptoms. I'm not trying to get a perfect result in a vessel. So in my mind, I'm thinking that just treat that focal, very tight lesion, because I have a good landing zone proximally. I don't have to touch that calcified area, and then just get out and see how it does.
So now that's a great question. Now Karthik and Vishal, to both of you, I want to ask you guys. So you talked about the impact data. I think he's a little lower than what he said, but still it's a very good 3-year patency. But the issue is what is the technical considerations of an impact balloon in this vessel and in this area?
I think PK impact. The problem using impact is you have to go to a higher sheet size.
Yeah,
you have to have a 6-fin sheet, so you have to use a 5-6 lander sheet, right? I think as we have seen it in radials, I don't think pedals will be any different. The higher the sheet size, the higher the occlusion rates. So I don't think 5-6 will make difference, but definitely because it's a one vessel runoff, I would limit it to 4-5, and 4-5 will give us either a plain balloon angioplasty, either direct stenting with a bare metal stent, which is not a supera. Again, I don't think this is a big flexion point, so it's okay. So it's fine to use a bare metal, and the bare metal is, if you're trying to just stent that focal popliteal, it's going to be around probably around 40 centimeter stent, 40 millimeter stent, 4 centimeter stent. Patency rates are 80 to 86% in 3 years, which is BMS is pretty good. And then if you are telling me you want to use a DCB, then you have to go with a barred balloon. Barred Lutonics balloon goes through a 5 French stent, a 4-5 slender. So we have 3, but again, when we have Lutonics data, I think now you're looking at almost if you look at a 3-year this focal lesion, I think the 3-year patency rate is not much different than impact, but definitely less than impact.
Well, it's hard to say because obviously Bard hasn't published their 2-year and 3-year data.
Right.
So there's a lot of DCBs aren't created equal because the excipient is different, the dose is different. But you know what? I think you and I both know if we used a 30 millimeter bare metal stent in this lesion in the SFA, our patency would be excellent in 3 years.
I agree.
Agreed?
I agree.
So if you did a balloon angioplasty alone, it might be a little bit less. But it still would be pretty acceptable at 3 years, because if you look at the PTA arm, and we don't have the breakdown in the impact of short lesions versus long lesions, in this type of short lesion, I bet you that the difference between PTA and DCB may be very, very negligible. We don't know, but it might be negligible.
Yep.
So in this case, to me, I agree that since Lutonics doesn't have long-term data, that's an issue. But at the same time, the lesion length, I think, kind of evens the playing field, so you don't have to worry about it.
I think so.
So Vishal, talk a little bit about what are the things that you're going to do to get access in a safe manner that's going to protect our patient against having any complications at this level?
Right, so getting tibial access, we have to first demarcate and define the anatomy. So we do it angiographically, and of course we define it by the ultrasound as well. Here we have a full ultrasound machine, which we're lucky to have, which will show us the anatomy, the flow and everything. Some people use vessel finder or side try to do it, which is acceptable as well. But my idea is to try to see where you actually want to get the access. We usually try to avoid access into the feet because as the vessel tapers down, there's higher chances of occlusion and thrombosis. So we keep it around the ankle area or at the hinge point or higher up.
Right there.
Right up there.
Yeah.
And then, of course, we use the ultrasound. First, we'll just do a plain ultrasound run to see if there is any calcification, any narrowing, which we can ascertain either both by regular ultrasound or by color flow. But once you have defined the location and the anatomy, then we can explain to you how we get access by just trying to get all ultrasound guided access.
So why don't you show us the anatomy? And I think while he gets it ready and we're going to go live to show it to you, I think this is the one area, and you know everybody's seen me here for a few years doing this. You rarely ever see me touch the probe. I have an allergy to that probe. But the truth of the matter is this is where I think it's incredibly important to interrogate the vessel. Because you have a single vessel, angiogram is going to give you a lot of lies that you're not going to understand. The ultrasound is going to tell you exactly where you're going to get in, which is very, very important. So you see Vishal now, he's going to interrogate the vessel, and he's going to find a spot that's going to be without plaque as much as possible. We know that everything is going to have plaque. He's going to find an area that's going to be without plaque that he's going to enter that's going to have a bony prominence in which we can go ahead and hold pressure. So you can see something. I'll tell you. Go ahead, Vishal. You describe it.
So we start from the foot. We define the DP. That's my DP coming up. Here, we're lucky enough to see the pulsations, but if let's say you have an anterior lesion, a lesion more proximally, you might not see a classical pulsation of the arteries. So that's one of the things in the pedal axis you really have to know, especially if you're accessing, let's say in this case, you're accessing the posterior tibial, you might not see pulsations at all because of the flow limitation. So here you can see the pulsatile artery right there. Even if you try to compress, the arteries in the tibials can compress to a certain extent. You know how we define vein versus artery, try to compress. One is compressible, one is not. If I try to compress, it still compresses to an extent. So this is one of the define the anatomy. So we actually follow the artery all the way up to see how it's doing. So here you can see there is some degree of calcification, but not that bad. The lumen size is decent and it's actually increasing all the way up. And this is where usually our spot point would be to get an artery. Look how the lumen really suddenly goes up from a DP to a distal AT. So this I think should be a good spot, which is away from the feet, above the joint, and it has good lumen with the...
And how about any plaque? I think this is important also, Karthik and Sandeep. You guys got to find an area which is relatively plaque-free, which is baloney, we know that,
Right.
but at least have a little bit less plaque. And then you have to look for proclusions, like severe calcification, things like that are going to cause dissection when you go in with the sheath. So, and also you want to look at where the bone is to see if there's any compressibility for you to be able to get in as well.
Right.
So you also want to compress this, and we can talk a little bit about anticoagulation, because as of now, he has had no anticoagulation. So go.
Right, and then in the tibial, you can go long axis also to define the calcification. See, I'm long axis, right there. And there is some calcification, but it's very minimal. It's more medial. There's nothing really intraluminal to really preclude us from not getting this AT access. So I think this AT is a relatively healthy AT to get an access into and hopefully do our case. If we have to, let's say even upgrade to a 5 or 6, I think we still have room to go 5 and 6 if we have to, if we decide to do that.
So then, okay, so now I'm going to ask Asma, actually, Vishal, do you want to, I think all of you know how Vishal is good at getting this access. We're going to get access offline and have Asma present some of the equipment that's available to you guys so you can understand how this is going to work. So let's go to the slides for Asma, and we're going to come offline here. Here we go. Okay.
All right, so some of this we already covered, and at the risk of being redundant, I just want to skip over it. So why we're choosing the non-traditional, alternate access points, we talked about it, tight bifem, aorto-bypass bypass, previous endovascular repair, like a AAA repair, which he had as well, extreme angulation, and iliac artery occlusion. And also some of the things that preclude, like we talked about, integrate ipsilateral CFA access would be like morbid obesity, infected groin, prior surgical scars, and patients with hip contractures. Next. So what are the alternate access points? We already talked about. So integrate femoral, transradial, transpedal, brachial, which many of us shy away from because of risk of complications. Next. So radial access for peripherals. I want to highlight this slide. Actually, it's a very good slide about the anthropometric measurements. which basically precludes us from using many of these devices below the knee, because we don't have in our armamentarium that many balloons and stents or atherectomy devices which are 200 centimeters or more. So if you can see from the left radial, the left radial to subclavian, there's it's in an average size male, so it's about 50 to 65 centimeters. Left radial to renal is about 90 centimeters. Left wrist to common iliac is about 100 to 115 centimeters. To popliteal is about 155 to 170 centimeters, and to the foot is about 200 centimeters. Next. So this is a very busy slide, but it shows the current available transradial peripheral vascular intervention devices. So this is mainly focusing. This slide is about the PTAs and the and cutting balloons and self-expanding stents. And here you can see on the extreme right of the slide is basically the shaft lengths. I don't know how well it translates. If you all can see that the shaft lengths basically are anywhere between 130 to 150, and only Bard has one device, which is one balloon, which has a 200 centimeter shaft length. Most of the other ones are around 135 centimeter. And in the bottom of the slide, you can see the self-expanding stents. They, Abbott, Bard stent, or Silver is about 120 or so. So most of them are in that range. Next. And then here, the top of the slide again is a continuation of the stents, and it's basically showing you the Gore Y-band again, 120 shaft length, and and the balloon expandable stents are also around the same. Atherectomy devices, again, you can see 120 to 140, and the CTO crossing devices. Basically, all of these are the maximum shaft length is around 135 to 145. Next. So I want to highlight this so as we all know, Terumo is kind of dominating the radial space in coronaries. From coronaries we know, but that technology they've been trying to extrapolate into the peripheries as well. So this is a cross-sectional area, the inner and the outer diameter of a glide sheath cylinder on the right side, and on the left side it tells you how it compares to the standard introducer sheath. So the glide sheath for the 4-5 the 4-5 sheath, it's around 2.13 millimeters in diameter. The 5-6 sheath is 2.46 millimeters in diameter as compared to 2.62, which is the standard sheath. Similarly, the 6-7 sheath has an outer diameter of about 2.79 millimeters as compared to the standard 7 French sheath, which has a diameter of 2.9, almost 3 millimeters. So
Next.
so now Terumo is coming with the dedicated radial equipment, and this is the glide cylinder, the destination cylinder, and the stent glide, which is basically a guiding catheter. So the glide cylinder is just a short cylinder sheath, essentially, from we use in the coronaries all the time. However, there's also a destination cylinder they're coming up with, which is essentially around 119 and 149 centimeters in length, and it has the same qualities of a destination sheath and with a hydrophilic coating. So then there's a stent glide, which is 7 French 7 French. It's essentially a guiding catheter, and it has distal hydrophilic coating, and it has 2 lengths, 120 and 150 centimeters. So these are expected to be released sometime this year. Next. And then we have these 2 dedicated radial peripheral balloons that Terumo has as well coming up, the Metacross and the Misago. So essentially both have 200 centimeter shaft lengths, and they are 3 to 8 millimeters in diameter, and Misago's 6 to 8 millimeters in diameter. Next. So that was about the radial peripheral space. Now, talking about transpedal access as an alternative, which is what we're doing here today. So I just want to focus on, this is, we know about this, the pros of transpedal are, mostly used for CLI, and if there's a short segment occlusion in a tib or a pop, and where the proximal cap is difficult to cross, we can go transpedally. If there's just one vessel runoff, and there's for whatever reason we cannot use embolic protection, this access can be used, and many also in hostile groins and everything that we talked about basically. Next, the pedal anatomy, which Dr. Kapoor and Dr. Krishnan highlighted very well, but I just want to talk about it a little bit here. So essentially, the anatomy of the foot vessels, essentially there are two dominant vessels in the foot, either the anterior tibial or the posterior tibial. The anterior tibial becomes dorsalis pedis at the level of the ankle, and then essentially becomes the arcuate artery, which then divides and dips down into the and as a dorsal artery of the foot, and it forms communicates with the lateral plantar artery, and it becomes the pedal arch or the pedal arcade. And on the other hand, the posterior posterior tibial artery at the level of the foot. Yes. Posterior tibial artery becomes the plantar artery at the level of the ankle, and it divides into the medial and lateral plantar arteries. The medial plantar artery supplies the medial aspect of foot, and lateral plantar dips down and communicates with the other artery from for the dorsal artery, and it becomes the pedal arcade or the pedal arch, which is very important for, as we know, for the viability of the foot. Next. So pedal access, as they're doing it, I'm just going to spend a minute about this. So ultrasound-guided, as Dr. Kapoor very well demonstrated to us. So we typically use a micro-access sheath, which is Cook's micro-access sheath. And we use a 21-gauge needle, a 4-centimeter echogenic needle, and it's a small 7-centimeter micro-access sheath, which is again four French, and the wire that comes with it is an 018 nitinol wire, and it also has a hemostatic valve. It's called the check flow, which essentially turns this little micro puncture sheath into a guide through which we can do the rest of the intervention. Again, we use the same cocktail as we use for radial interventions: nitro, heparin, verapamil, which we used. Next. And this is just demonstrating the flow check and the microaccess sheath, and it's showing Cook's CSI device, which is also for French, and it can be used in that. And that's it. That's all I have. Thank you.
No.
This doesn't have heparin.
Did you put heparin in that? No, not heparin.
No.
Give Angiomax.
Yeah. No, we give Angiomax. Yeah.
Okay.
So PK, what are we introduce the
so-
sheet now?
So we took a sheet, and I hope we didn't inject. We just injected some. We got access. We put a 4 French micropuncture sheath. You can see here there's an injection with a little air, but that's okay. And you can see here that the flow it's almost occlusive with just a 4 French sheath. So you can see here. So we've given our cocktail of heparin. We've given our contact of verapamil and nitroglycerin. And so now he's going to get ischemic in the foot. So now what we're going to do is we're going to go ahead and take care of this very, very quickly.
Right.
So we're going to give Angiomax, guys? So what would you do? Would you do Angiomax or heparin? Let's take a vote here, because there's no. What do you guys think?
I always do heparin, PK.
Okay, so how much heparin do you give?
So I usually give around 5,000 heparin as an average, but normally it's around 60, right? 60.
So let's
body
do.
weight.
How much does he weigh, guys? So let's do weight-based heparin. I agree with that, because we do have an access in a pedal vessel, and we're going up, and it might be worthwhile in case we need to change it. We're going to change that sheath in a second, Vishal.
Yeah.
Say 86 kilos. So if you're saying 60 times 8, right, is around 4,000. So we'll give 5,000, right? We'll give 5,000 of heparin. Let's give it through the pedal sheet.
Yeah.
So we're going to give it right through the
So
pedal
PK,
sheet.
there are a couple of Asma. You went over the whole technique, but there are a couple of school of thoughts when people talk about TAMI, right? TAMI is transpedal arterial invasive, minimally invasive technique. So a couple of people do it differently. When they access the PTs, there are some markers on ultrasound. Now that pedal access has become, there are some approaches for pedal first. So when you do dorsalis pedis access, the normal school of thought is you track the ultrasound until the level of the lateral tarsal artery. So the dorsalis pedis kind of bifurcates into lateral tarsal artery and the medial tarsal artery. So you want to get your access before it bifurcates into the lateral and the medial tarsal artery, right? Especially if it's a one vessel like this, it becomes a very dominant artery. So even the medial tarsal and lateral tarsal and the medial tarsal look pretty big. They might be pretty big vessels. So the reason for getting before the bifurcation is the amount of sheath size you can put is much higher, right? That's one school of thought for dorsalis pedis. The another school of thought is people get access above the level of the ankle, as PK was talking about, the hinge joint. So PK, how do you usually do it? Based on the hinge joint, or?
You know, Karthik, it's so funny that, you know, when I hear you guys do all this stuff.
Fine.
I'll take this out, right?
Yeah, unscrew it.
Yeah.
Perfect.
Don't tell me you're a dinosaur. I mean
No, I mean, truthfully, I find that, you know, in this kind of case, it's very important for us to be able to do this with a ultrasound. You know, you can see with Flora, please. Everything on the ultrasound on Flora is what you got to watch. You know, so right here, we're gonna put the wire on the Flora. We're going to watch where it goes. You know, and then we're going to put our sheath. But to me, you know, generally speaking, I would have probably done this without ultrasound. But you know, I think it adds a layer of, hold on a second, and let it bleed back. Adds a layer of safety to doing this. The second thing is when you go with this 4-5 slender like we're doing now, what we're going to do is we're not going to introduce it all the way. You need to lubricate the sheath very nicely with a wet one. I think that's very important, and it's under appreciated. And I think what you need to do is as you go in, you just need to be very careful as you jimmy it in. You know, as it is, you can feel a lot of resistance inside the groin as he goes in. So he probably needs a dilator as we go in here.
So PK, a lot of people say you can make a small nick because it does less injury at the level of the access site. And it's much easier to attain hemostasis if you actually make a small nick at the skin site.
Agreed, and that's what we're going to do. But what I generally do is get a dilator in first. And, you know, even with the dilator, he has a lot of issues just getting it into the foot. So here goes the dilator into the vessel. Okay, the dilator is in the vessel. Now I'm going to get a little nick. So I'm going to borrow the knife. I'm just going to ask Vishal. I'm just going to stretch the skin and have Vishal make a slight, small nick, right at that level. Watch the blade, which way it's pointing. Okay, and there you go, little nick on that side. Okay, very good. So now that we made a nick on the side, I'm going to walk it out. The other thing is also how far do you want to extend the sheath into the body, right? Because remember that the sheath also has a taper to it. So you want to go ahead and extend the sheath into the level of the body with a nice taper where the taper is, and you don't want to extend it as it is because it gets thicker as it gets further distal to the hub, right? So that's also very, very important.
How much do you usually put in, PK?
About maybe 1/3.
Okay.
That's it.
Okay.
Yeah, so Vishal was worried because, as he knows, I'm talking and doing this, I probably pushed the wire all the way in. So now, the second thing we're going to do is, we're going to go ahead and give more, I'm going to give more nitro and more verapamil into the foot.
Right.
Every time I do a sheath exchange, we want to go ahead and do this. And then we're going to, is it time for an ACT? Is it time for an ACT?
Vishal, how much sheet do you put in?
Before you do that, give me an ACT syringe.
Sorry, what, Karthik?
How much sheet do you put inside?
About 1/3.
1/3.
I'm just going to go ahead and get an ACT syringe here. Okay.
And
Yeah,
one question, in this case, we didn't have an option
Give me another
between DP and PT. If it's a balanced arch, let's say, do you prefer one over the other? If we had both the options,
How much
PT and
nitro is
AT?
this?
I mean, personally, I always prefer the DP, Sandeep, only because of the hemostasis.
Give
I
me
mean,
some.
you have more bony landmarks
Give me
to
a
attain
flush.
hemostasis, so it's much easier for the
Verapamil?
patients. PT, usually the bony landmarks are much hard to attain. Hemostasis is hard to attain. So they usually have more
Verapamil?
vessel closures or
He's gonna burn,
hematomas
sir.
with PT.
It's all good happening.
Vishal and PK, what do you guys
whole
think
thing,
as
right?
Sandeep? I think it's a very good question, PK.
Yeah, so I usually again
Flush.
try to do the DP part because, like you said, it's accessibility, using of ultrasound, and PT. It could be harder because you're behind the medial malleoli. If people are really thin, you
Give
have
me
a
a
really like
a run-through wire.
crater where the ultrasound
Actually,
doesn't
give me a
go in
Spartaco
well.
wire.
So for me, DP is more accessible and easier to control against the bony spots. So I prefer DP.
PK, you do the same.
What's that, buddy? DP or PT?
Yeah, if it's a balanced,
I mean,
It's
to
a
me,
balance.
I just pick the healthier vessel. I mean, and I think this is where we go with the indication on what we're doing, right? I think your indications have to be very, very correct. You have to have a conversation with the surgeons. You have to have a conversation with the patient. I mean, in this case, this poor patient was going to undergo a fem-pop bypass in a redo groin for the question of possibly having this issue of being a severe claudican. So I think that this is clearly not something that you're definitely doing a service to him by helping him. So that's kind of the reason. I think this is where I don't think it matters what access you get. I think it matters more the show me that more the level of the level of the indication that you have for this procedure. I think is much more important than the choice of access vessel. So here's the vessel, obviously not a very complex lesion. Things are going to fly up, and that's what they did. Got a nice C loop, so I don't need to worry about this. So I'm going to walk this out. Now I'm going to get an IVUS. And the problem here is you got to worry about the sheath because you don't have the sheath all the way in. You don't want to pull the sheath out. So we're going to just watch the sheath here. I mean, Vishal's going to tape it, but even then you have to be very careful.
PK and Vishal, a small question. Every time you do exchanges of any equipment, balloons, IVUS, atherectomy devices, do you guys give cocktails?
I do. That's what we just did. We exchange the sheath, we give cocktail, but not every time. It depends on the ACT. I want this AC to be over
No,
3.
I'm saying not heparin PK, like nitro and verapamil. Do you guys do
I-
vasodilators every single time?
It depends on the size of what I will do. I think when I do my Lutonics, I definitely will. But I think at this stage, I've got my wire cross. I'm going to get my IVUS, and we're going to load the IVUS.
Vishal, do you do vasodilators every time you exchange?
Well, I mean, again, it depends, right? I mean, if I feel a lot of, if in this case, let's say, I try to use as much as possible. One is the blood pressure, of course. And if there's a lot of spasm I feel, if I have to do just PTA, DCB and out, then we usually try to do it within 5 to 7 minutes and be done and hopefully decrease the chance of spasm. But if I'm planning to do like atherectomy, DCB, stenting, multiple steps, multiple exchange, yes.
And I think
Prophylactically,
and I think that's what I want to talk about is that with the billing and all this other stuff going on with the OBLs, a lot of guys are running atherectomy devices through the leg. And let me tell you, there's absolutely no benefit in running an atherectomy device from the leg. You just have the incremental risk of a larger sheath, more embolization, and really you're not increasing your patency rate by any way. Now I do get it if you're in a CTO and you want to do a sort of a laser, you can't cross anything. Okay, that makes sense, but then your indications are different. But for these kind of isolated SFA type lesions, there's absolutely no reason for you to do that. So, here less is more, and I think that's what everybody has to understand. Less is more in these cases. So please, when you guys are picking pedal accesses to do this, I think this is our second case we've done. We did one live in Link, New York. To demonstrate stenting through the leg, show me above. And then we did one obviously now. So here's our IVUS catheter going. I'm going to go into the distal SFA, and then I want to record. And then we're going to do a little pullback. Okay, doing a little pullback. You can see not much plaque, and you can see it's just a lot of calcium.
Just medial calcification.
Just medial calcification.
And
And you're going to come to the level. Here's again calcification. And then you're going to come to the level of the lesion, which is much lower, right? Which is going to be
There's a healthy segment there.
There's a healthy segment.
There's a
right
healthy
in the
segment
middle.
in between.
right about
right
there.
there,
There it is.
right
There's your
there.
lesion, like we
Right
talked
there.
about.
It's really
Okay,
focal. like a
focal,
point.
and then
Yeah.
out.
Yeah.
It's like a 2
So
centimeter
should
lesion.
do a focal.
now let's get a measurement on that, guys. Walk this out. I'm going to hold the sheet.
Focal.
Let's get a measurement on that for me.
see, I think that's a great point. Using an IVUS, you can, if you do angiographically, you're tempted to fix that proximal segment, which looks crappy, doesn't look that healthy, and you end up ballooning a longer segment. But if you do an IVUS, it actually pinpoints focus, and then you can really do a focal directed treatment. And
208 is
cause
my
less
ACT.
It's
Complications.
around, it's a
208
it's
is
almost
my
like a
ACT.
5
Where's my-
vessel.
Can I have more heparin? ACT is only
Plus
208.
Vishal, I think it kind of gives you a definitive
she go?
answer as to the landing zone. There's a healthy landing zone.
208 is my
approximately.
ACT.
So sometimes
Damien,
IVUS
where's
does
Liz?
help, definitely. And this is where it has one of those roles to do a focal guided.
ACT only 208. And more. Yeah, we have to
in
give it through the
your
sheet.
practice, what is a post care you guys recommend? Like, for radial, we typically recommend them to take it easy on the how they use that wrist
Yeah.
for next. For
No, that's not the
48 hours.
lesion. Can
So
you
I
can
usually ambulate them. So I felt like
Can you
pedals are much easier than
measure right
radials.
there, Damien?
So
wait,
I
go-
personally
go
ambulate
down,
the
come
patients
down,
in
come
30
down,
minutes.
Come down, come
So
down.
in 30
come
minutes, I
down.
usually discharge the patients. They can go home. They can
A little- a
ambulate.
little
I just
higher,
tell
yeah,
them
measure
not
there,
to
measure there.
run or do vigorous exercises, but they can
Give
do
me
anything they
help
want.
with 280 is way
Walking,
too low.
everything is
Anything they
3,000
want.
if I can,
Actually, the
please.
more they do, the better it is. Not
Yeah.
running, but the
Right.
more they ambulate, the better it is because they cause more vasodilation
Come on, guys.
in the feet, and they actually do very well. So, PK and Vishal, do you guys have any preferences of the post care?
Well, in terms of care, I mean, it's basically pull the sheath on the table, hold pressure. The ACT is really low, it's 208. So we're giving another 1,500 of heparin. Does that sound reasonable to you guys?
Yeah.
This is how much total? Okay, so I'm giving, 1,500 more of heparin. Dump that, please, for me.
Yeah.
And then now, this way at least we get the ACT to be therapeutic. And then now that we have a vessel size around, well, let's see, that's not going to work. Let's 1, 2, 3, 4, about a 5 millimeter.
It's a 5
5
millimeter
millimeter.
vessel, PK.
So
Yes.
that's what we're
Yeah,
going to do.
take a
We're going to do a 5
5/20.
millimeter balloon. Give me a
I think we should,
5020 Latonics, please.
Can we switch from IVUS to PK's angiogram, please?
Yeah.
Thank you.
5020 hours.
5020 Ivis, please.
Okay.
Latonics.
So you want to take a 20 balloon PK or?
Yeah.
Yeah, just a 5020. That's all. I just want to do that focal spot and get out. So you can see here it is. The question is whether this 014 wire is going to have enough body to take it up. And that's the question.
It does.
Yeah.
I mean, it does.
It's a run through, so we'll see.
Uh,
Give me a 5020.
So it's interesting, PK, how you and Vishal have different thought. I always access the CTO vessel, so that's my way of doing pedals.
Oh, 40 is fine. 40 is fine.
Fine.
So Vishal, you always go to the healthiest vessel, is that it, or?
Yeah, I mean, usually that's what we try to do is do the healthiest vessel. Like if
Okay.
there were no restrictions really, and this focal spot, I would have done a longer. But I think the IVUS adds an extra eye to it,
Okay.
and that's where.
But at least from my standpoint, every time I do it, I always try to access the CTO vessel.
I mean,
So I feel like,
But you know what? I agree with you. It adds a layer of comfort. But I mean, to me, just because you access a CTO vessel, then you could perf that CTO vessel. You have another
Yes.
issue.
Yes.
So on and so forth. To me, I think that if you do it properly, you do it under IVUS guidance, you keep your anticoagulation straight, you keep giving your cocktails, and then you're very quick with your decisions. I think you're okay. Once you do that, I think the issue is you just want to be very, very straightforward with what we're doing. So here now, we're gonna give a rail. Can you get a rail for me, please? So then we're gonna go forward with this balloon here. And again, in my hands, I'm feeling for any resistance, anything like that. Okay, so far, I've got a little bit of
So
resistance coming
Sandeep,
out
do
of
you
the
do it?
slender sheath.
How do
right?
you handle the pedal access after
terms of-
post care?
Should go. It's just the
Post care,
angulation.
I haven't done many, but I think I would be careful, exactly what you said, not to tell them to run or anything, but usual activity should be fine. Manual compression. There are some
Right.
people use a band and
Agreed.
pressure
A little bit
dressings.
higher up.
But
Why do you wanna
I
go
would
higher
make
up?
sure,
That's
a
especially
bridge
like
area,
in
right? You're
this
gonna
guy,
dissect
if
it,
it's
no?
a single
Okay.
vessel
You
outflow,
wanna
You
keep
wanna
it? Yeah,
go
no,
I
it's
would
fine.
definitely
No,
check
it's
it,
fine. Just
a little bit
half an
higher.
hour,
That's it.
and
Okay.
then
That's
at
it.
least.
Okay. But you may dissect here.
Okay, so
Yeah,
move
that's
on.
okay.
This is
That's
all
fine.
P-
Do you
PK
guys like this, or do you like it back?
would-
PK, you took a 40 millimeter balloon.
There's
or?
only the smallest
That's
is
all
40.
they have.
Walk
I
I
back
think
a
that's
little bit.
good.
Yeah, I like this area right here. So we're going to
very
stay
good.
out of that dissected
Yeah,
segment.
exactly. Yeah,
We're
the
going to go up
calcified area.
slowly. See, Liz?
PK, I would actually go a little bit higher, don't you
Okay.
think?
Why?
Lesion is.
Why?
We are too much into the normal segment, right? Why do
But
you want to be so much into the
Yeah,
normal
but I
segment?
don't want to dissect, so I'm okay here. Go up.
Okay,
Then
Yeah, I
you
don't
can
wanna
calcify,
dissect.
right? With a
I think
higher,
it's
we
okay.
may-
Yep.
I think it's fine. I think it's a 5 millimeter vessel, so it's okay. It's more medium.
no, in the
calcified.
calcified,
Slowly, slowly.
that's a lesion.
There it is.
That's the
Perfect,
lesion.
save that.
Yeah.
See how tight that image is there, right?
Yeah.
You can see that it's really just a tight spot for him. And we're just going to go up very, very slowly and then try to crack that lesion. Now, you could argue that, atherectomy is going to make this better, blah, blah, blah.
I think it-
I
at
think
this
it's a lot of
model,
bull.
it
I think
doesn't.
it's a lot of bull crap. I don't think that's true. I think that this is something where it's very simple. We need to get in, get out, and that's what we're doing right
PK,
here.
we have been told by the audiovisual team that the BC has been deleted out of the conversation. So
Oh my God, I'm sorry. Did well, no, I thought, oh, you're right, okay.
it's been muted. Don't worry about it.
Okay.
I
I
think you're
Already.
allowed to say that part, no?
mean, that's not a bad word, you know?
But Karthik, also for the records, because you're online. And
Dr. Ashnan, one question. Like,
Yes.
you know, after this balloon, once you deflate the balloon, would you let the sheath bleed when you take
Absolutely. I
Yeah.
think what you do is you go negative.
Yeah.
You open up the stopcock of the
Yeah.
sheath as you
And
walk
then
it
let it
out.
bleed.
As you walk it out, you're going to drag a lot of material down with it, and hopefully all that material will just bleed out through the sheath. And then you can do active aspiration the way we do in carotids
Yep.
to go ahead and actively aspirate the sheath as soon as everything comes out, as the balloon is coming out towards the sheath. The important thing here is you want to go ahead and do the numbers properly here. So you've got one shot at doing this right and doing it properly, and right now at this stage, all you're doing is going ahead and doing a Lutonix balloon at this issue. The one thing we haven't talked about is, God forbid we have an issue with the access vessel. How do you deal with it?
Yeah.
So let's talk about that in this case. And again, I think that's the decision, and I think it's very important. And I can tell you, I've already thought about this. So at the level we've got it, if we need to do a cut down and a repair of the dorsalis pedis, it's not something that we want to do. We can do it because we have the ability. It's right at this level where it's easily accessible. And we've already discussed with the surgeons. And I think this is what I want to talk to all the cardiologists and radiologists about that. You've taken this guy from a fem-pop bypass with all its comorbidities, et cetera, to the worst case scenario, a cut down of the dorsalis pedis and a repair of the DPs with a patch. So I think that it's not a procedure that every surgeon wants to do, but I think that it's definitely less morbidity for the patient. And the idea is, the problem is percutaneously to manage that will be very difficult. And I think that's where Karthik's logic of getting the occluded vessel works, because the vessel is occluded anyway, you can't make them any worse, and that's true. But I think in this case, we had trouble with a 4 or 5 slender getting it through this vessel, which is not an occluded vessel, so I can't imagine how we would be in an occluded vessel to push this up. So, and I think that if you did less than a Lutonix or a drug-coated balloon here, then obviously you're giving this guy inferior therapy. So I think he has done so well with drug-coated balloon drug-coated balloon that I think that this is the right thing for him. And that's part of the reason why Asma and I didn't want to move it up into the distal popliteal or the proximal popliteal if you're coming from an antegrade view. Because I don't think we want to dissect this. So we're in the segment that's relatively healthy. We're at 3 minutes. We're going to go down. So when she goes down, I'm just going to start actively aspirating. Okay, as the balloon comes down, the blood will come. And if the blood doesn't come, as she walks it out, the blood will come. So I'm just going to keep it on active aspiration. And then we're going to come off roadmap here, Ray. Ray, come off roadmap. Yeah. Okay? And then I'm going to wait for the balloon to completely come down and the bubbles to stop. And I think this is the kind of discipline you have to have. Great. So the bubbles have stopped like carotid. I'm just going to fix my sheet, and I'm actively aspirating as Vishal is going to start walking it out.
Pull, so I'll push it in because I don't want the sheet to come out. So if you
No, I've got the sheet. Don't worry.
So what you
Yeah.
do is you
No, I've got the sheet, though. It's not going to go anywhere. I promise. So I'm actively aspirating.
But you know how Karthik are experienced with things moving. and all?
Yes, I get that. That's
I'm
actually
still in
that's
PTSD.
that's very wise words, Vishal. I'm very happy that you're watching.
I
You
am
know,
watching
hold
one.
on.
You know, you
so
have
on.
to understand if
Okay,
the
go.
sheath comes out, it's still your
Go.
fault. So,
Go.
I know, my friend. We live the
but the
dream.
good thing is wire is still there, so it's
So
okay.
I have been actively aspirating here as the sheet comes out, and it's been very tight to get it out. So I actively aspirated about 10 cc's of blood, and I'm just going to let it bleed because I'm going to hold the sheath here. I'm going to have Vishal just hold that, and then I'm just going to let it bleed out. Yep, just let it bleed. So we're going to actively aspirate it out. Great. So now we've actively aspirated. Now I'm going to give verapamil and nitro into the sheath. The sheath definitely came back. Let me see the tip of the sheath.
Still okay. You had very good
You're
blood
still
flow,
fine.
PK, so it's
You're
okay.
good flow, you're still internal.
Mhm.
You had very good, yeah.
Right. I'm just going to make sure we give verapamil and nitro again.
Let me flush.
And I think our ACT, Elizabeth, is
Alright,
watching it.
so PK,
like a hawk.
Vishal, and Sandeep, you guys take a foot shot after you do transpedal access every single time?
No.
I mean, you have to. I mean, what else are you going to do? I mean, the problem is once you pull out the sheath, you're going to hold pressure for a few minutes. Obviously, with the sheath, it's occlusive. Then what you're going to have to do is take a picture. I mean, you can take a
Right.
picture through the sheath. It doesn't really matter because even if you've created an issue, you're not going to know till you pull the sheath out.
So,
we're just giving more verapamil through the sheath now.
So
Okay.
PK, what I have started doing is to recognize it before, what I started doing is I keep the wire there.
Yep. And
When I get the access with the micropuncture, I put the micropuncture back with a small 2.4 French sheet, which we have, and
100%.
take a picture and see if you have
200.
flow across that access point.
Okay. Well, you know, the other thing
Before I pull it out.
the other thing also that we talked about with Ray this morning was very simple: is putting a 018 Trailblazer through, pulling the wire out and injecting, and so seeing how the flow is into the foot. If the foot looks good, take it out. But my perspective is, again, what are you going to do with that? If you have a dissection at that spot,
Exactly.
you can't fix it, especially at the level of entry. You're either going to have to go up and over, which you can in this case. You're going to have to go antegrade, which you can in this case, which you can if you wanted to. It's going to be really risky. And you're going to have to get a surgical opinion. So I think it's more about making the diagnosis, rather than trying to fix. I think that's important. So to me, it's better for me to make sure I get adequate hemostasis, hold pressure, and then take a picture from above and see how the flow is. If the flow is not good at that stage, then I know, then I'm going to consider my options, but I'm going to do all that on the table. I'm not going to do it when he's off the table. So now with this situation here,
So do you guys do Doppler? Do you guys do Dopplers and check the pulses every 15 minutes when the patient goes out? PK, Vishal, and Sandeep.
in this case, we
Yeah.
probably will.
Well, that's what I usually do is I really don't do post
Okay.
axis angiograms because like PK said, what are you going to do? And you are going to see some slow flow anyways when you're holding pressure. The question is you have to rule out perforation. That's my biggest concern. So I just follow them, hold
Nice.
pressure, follow them clinically,
Take
do a
Think we're done?
Doppler, and that's pretty much what it is.
to me, I think we're done here. You can
Yeah.
see the flow is much
Yes.
more robust.
Yes.
It's not slow at all. You've got a nice lumen. You've got
Yeah.
no dissection that I can see. Now I can do an IVUS and look for the dissection, which I'm not going to here. Which you may say, well, Prakash, you're really playing the game here, but it's true. I mean, to me, I think one of the things I'm going to do here is just pull the wire back a little bit.
I mean, it's a DCB.
And
Even
then-
if you
and
have
then-
a dissection,
It's
we are
controlled
assuming that
dissection.
it's a DCB, so it's going
Right.
to heal.
So I'm just going to do another view here, just to see where we are, and then we're going to take a look, and you can see it's a very beautiful.
I think
Looks
it's a
very
very
nice,
nice
very
result.
nice result.
You got a little bit of plaque disruption, but that's okay.
Yeah.
So now I think what we can do is at this level, just take a look and see whether we see anything in the foot, and then we'll decide. Sir, don't move your foot, sir.
Oh, sorry.
No problem. So you can see here's your perineal filling the foot. There's your DP coming down and retrograde filling via the perineal. So I think you've got a viable foot regardless. And I think at this stage right now, what we're going to do is we're going to walk it out. If you want, if everybody wants, I can put an 018 catheter in and take a picture if that's what you guys want. You want me to do that?
No, not
No,
necessary.
no,
I mean, not necessary, but
We're looking for
Yeah,
things we-
I think at this stage, I think
I mean-
done. I think what we're going to do is we're going to pull the sheath out on the table, and we're going to hold pressure, and then
then
we're
take
going
a-
to take a look. That's
Yeah.
all.
Picture from above.
There's nothing else to do, right? I think we're done.
I think
All right. So I think this is a nice demonstration of this particular thing. You guys want to take the wire out and just pull it out. I'm just going to do a little quick wrap up here. I think it's a nice demonstration. I want to thank Asma for really putting all this together in the last minute. As you know, we changed the you have to take the wire out slowly. We changed our topic from a popliteal to this because we felt this is very apropos. The one thing I do want to ask, Karthik, do you wait for the ACC is 290 or you just pull it now?
no, I just pull it out.
Right, and that's exactly what we're going to do. So what Asma is going to do is make sure she has good control, which she does, and it's a DP, so it's not an issue. We're going to pull it out. She's going to bleed back and then grab a hold of the vessel to make sure, just like she pulls a regular sheath, to make sure there's no hematoma formation. Okay, a little bit of bleeding, and then just hold it. Is it robust bleeding, Asma, or no? Yes. So any clot that forms at the level of the sheath, like you do with a common femoral sheath, you want to pull it out. So two things I want to discuss here. I think Vishal did an incredible job of showing, getting the access in the dorsalis fetus artery. And Karthik went over the technical points of where to get access, where not to get access. But I think if I was to leave you with one take-home point is these are not radial vessels. The microvasculature distal to these vessels are incredibly diseased. Your hand rarely ever develops atherosclerotic disease, and the microvasculature generally is very, very healthy. So the misnomer that cardiologists think that, oh, if I can get a radial access, I can get a pedal access. Yes, technically you can. But the vascular surgeons know definitely that this microvasculature is very different. So you got to choose your indication. When you choose your indication, and I don't think you can have a better indication for this access than what we just did, you want to talk to your vascular surgeon to get them on board. Because we talked about all the things that can happen at this level, and so therefore you have to know your bailouts. In this particular case, the bailouts are not go up and over and balloon tamponade, because if you can go up and over and balloon tamponade, you probably should not have put a sheet to intervene through the leg. That's kind of the clue that you need to have. If you have an option to go up and over and do some sort of intervention, then the point is that this pedal sheet should not have been used most of the time. Okay, there are rare instances where you might need a sheet because you can't deliver devices. I get that point, but generally speaking, for a claudicant, that is a very important point to remember. And finally, watch your anticoagulation. Your anticoagulation is very important here. You know, I was panicking when our anticoagulation was 208. We gave medications. It was only 208 for a minute or so. So therefore, now you want to keep the ACT at around, like Dr. Guja said, around 300. In this case, it was around 60 units of heparin per kg. So I think it's very, very important to do that. Follow-up wise, it's very important to go ahead and follow this gentleman with ultrasounds. Dr. Guja and Dr. Kapoor talked about our protocol here at Sinai to do Dopplers and palpate the pulses every 15 minutes. Keep him in recovery for the first couple of hours to see how he does in terms of his recovery, and then only send him up to the floor. As far as ambulation, Vishal, the next day, what do you think? As far as when do you get them to activities of normal living?
They can ambulate in the next 2 hours, but the only thing is not to. I usually don't tell them to drive if there's right feet involved, because if it's at the junction of the hinge. But most of the times, no heavy lifting. But regular walking is fine. Exercising, not exercising, but regular walking is just normal activities. No exertional heavy activities for at least a week.
How about you? How about you, Karthik?
So I actually ambulate them in 30 minutes, PK.
Okay.
So I've ambulate them in 30 minutes. I personally feel, and there are a lot of the big school of thought is. Unlike the arm, as you said, foot is different.
Yeah,
the more they ambulate, the more they vasodilate. They actually, the chance of having transpedal closures are much less if they ambulate early.
Right.
Because they vasodilate, and actually the flow is much better and the collateral circulation improves. So actually it's a good thing to ambulate.
Well, again,
early.
it depends on a lot of things. It depends on what your ACT is when you pull the sheet.
That's right.
So his ACT is 300 when we pull the sheet.
Yeah, usually.
So by protocol, we're going to keep him down in bed and watch this foot for the next. It can open up at any time. So you can say, well, why did you pull it at an ACT? Well, think about what we do in the radial. We pull it very quickly, but here the microvasculature is more diseased. So therefore, you definitely don't want to leave the sheet in and wait for the ACT. The other thing you can do is you can put a radial band here and create compression in this kind of situation. Or what you can do is do what we call as a poor man's radial band. You can take a nice piece of gauze, make it nice and thick, take a glove and tie a knot and press on it. You can do that as well. So you can do a lot of different ways where you can put a pressure dressing to hold this down. But the most important thing is monitoring. The chances of getting a hematoma in the anterior compartment are always there. So you have to be very, very careful during this intervention to monitor that, because obviously you use the anterior compartment to go ahead and get into the popliteal artery. So there's a lot of things that we talked about in this case, and a lot of things for you to think about at home. And I think you've got a lot of good take-home points. I really appreciate you guys tuning in, and I want to thank obviously our excellent team on behalf of Vishal, me, and Karthik for letting us do this case, and we'll see you next month in September. So thanks again, and enjoy the rest of your summer.
Thank you.
I think that's a great job, PK. Thank you guys for watching and encouraging us and supporting us in doing these cases. So again, we'll see you next month on September 26th for the live case webcast. You guys have any questions, you guys can go on the website and review the case, preview the case, and email us the questions, and we'll be answering your questions. Thank you. Have a great day.